biopsies with C4D deposition will not be associated with HLA antigens, and it is estimated that at least 38% of chronic allograft loss is due to antibody formation against the non-HLA targets. How do these form? Because of the polymorphic nature of some of the non-HLA antigens, the way of sensitization may be analogous to those of anti-HLA antibodies. Another possibility is that it is connected with ischemia reperfusion injury, because when you have ischemia, you have a damage of the cells and these are exposed. When they are exposed, your body forms antibodies against those, and these autoantibodies are formed, and under physiological conditions, the antigenic determinants from the targets for the non-HLA are protected but become accessible after this injury. Liberation and presentation of non-HLA antigens at the time of ischemia reperfusion injury may induce an autoimmune response. Non-HLA antibodies may also be secondary to immune activation or in connection with acute rejection. So when you have an acute rejection or you have anything which is denuding the layer of the cells, it can expose the donor allograft cells and cause antibodies against them. Anti-ETAR, that means endothelial antibodies, may also alone induce endothelial activation, stimulating pro-inflammatory and pro-proliferative and fibrotic response. So, how do they cause damage? The relationship between the non-HLA antibodies and graft failure does not automatically mean that the antibody is responsible for the graft injury. It is an indirect damage sometimes. It may specify non-pathogenic spectator activation that is triggered by aggressive immune response. So synergistic effect of HLA antibodies is the first which is documented. So if you have a PRA positive, they may not be antibodies against the donor, but they may just be HLA antibodies. That is why we say that when people have HLA antibodies and they are not against the donors, still your outcome is inferior to those who do not have antibodies. So they may synergistically cause a damage. Complement cascade activation can activate these. Endothelial cell activation by damage of endothelial cells. Natural killer cell activation. So these are the main pathophysiologies which are elucidated in literature. And what are the consequences of these HLA bindings? So all these antibodies, non-HLA antibodies, when they bind to the graft, you get antibody formation, you get endothelial cell activation, you have cellular adhesion molecules expression, cytokines are released, coagulation cascade is released, migration of inflammatory cells happens in the graft, and then there is tissue destruction via the complement activation, thrombosis and cytolysis, which is relevant to MICA. The other things are relevant to AT1 receptor and endothelial antibodies. Now let us look at MICA. So this was discovered in 1994 by a gene bank search for sequences related to MHC class 1 genes. This is on chromosome 6, like we have all our histocompatibility complex which are relevant to transplantation. They were named as MIC, MHC class 1 chain related genes due to their chromosome location. MICA is highly polymorphic in its extracellular domain and at a strong linkage disequilibrium with HLA haplotypes in specific populations. This system is highly polymorphic and thus there is a high probability that the donor and the recipient will be mismatched for these antigens, and approximately 100 alleles have been identified. So these are expressed on endothelial cells, which is the target for recipient's immune response in acute and chronic humoral rejections. Under normal conditions, these are not detectable on quiescent endothelial cells, but its expression may be induced by stress and cytokines. MICA does not interact with T cell receptors, but with the natural killer cells found on the ligands and on the CD8 cells. So natural killer cells are eventually activated. MICA cannot fix complement. So will cause a C4D negative ABMR. Remember this. So when you see a C4D negative ABMR, this might be one of the causes. So routine cross matches which are performed against the T and the B lymphocytes, not endothelial cells. Hence MICA rejection will go unrecognized. So remember the pathophysiology. If you remember that, you will know which type of test is going to help you in what. Now, this is one of my papers where I was one of the persons in the study when I was working in the HLA lab in Toronto, where we looked at cardiac allograft dysfunction. I used to work in a multi-organ transplant department along with the HLA lab. So we had a chance to look at lungs, heart, intestines, everything. So we looked at MICA, whether MICA was going to cause a relevant allograft dysfunction. And of the 36 patients which we studied, that time it was not very common. So we studied 36 patients who had allograft dysfunction of the heart. And we found 13 had detected MICA antibodies prior to transplant. But there were no differences between the two groups. So we had concluded at that time that there was no observed association between presence or absence of MICA antibodies in pre-transplant class 1 or class 2. But further, when papers started coming in kidney transplants, in heart transplants, they were attributing MICA to a lot of rejections. So this is one of the papers in 2007. So this was the time when all the solid phase assays has come in, and people were now saying that if there is no HLA DSA, why is there a rejection? So these were the studies during that time where this study said that pre-sensitization of kidney transplant recipients against MICA is associated with increased frequency of graft loss and might contribute to allograft loss amongst recipients who had well-matched HLA typing. So this is our answer to siblings or to people who are well-matched or who are fully matched and get rejection and we cannot explain it. What is our experience? So this is a small study which we have done in our lab between April 2021 to March 2022, so approximately a year. 302 consecutive samples were studied. 20 samples, that is 6.6% from 19 patients were positive for MICA antibodies. 5 of 20 patients, that is 19 patients, pre-transplant. 2 listed for deceased donor, 1 for lung, 1 for kidney. 2 who underwent a living donor renal transplant, PRA negative, 1 had ACR. 15 out of 20 patients, 15 of 20 samples, that is 19 patients. Why 19 patients? One or two patients may have more than 2 samples. 10 patients with suspected rejections. If you look at the dissection of this, had ABMR and 2 patients had DSA positive with MICA positive. 7 patients had PRA positive, DSA negative, as the donor was DSA could have been not identified because they did not have donor HLA, but had MICA positive. 1 patient had PRA negative, MICA positive. 2 patients completely matched, but MICA positive. 5 patients with MICA positive picked up on routine post-transplant monitoring had higher creatinine levels noted. So if you go to see, MICA is playing some role. This is not an extremely huge study, but this did show us that there is some importance of doing MICA where you cannot explain why the graft is not functioning well. After that, what is our experience? So then we started MICA SAB. So this was just a screen test, which I showed you before. But henceforth, after 2022, we started doing MICA single antigen bead assay like we do for Luminex. And we found that total out of 39 total tests, 2 were positive. Now, these 2 positive patients also had a higher creatinine is what we noted retrospectively. So, but can we say that this MICA was donor specific? No. For that, I need MICA typing. So, I cannot 100% say that these 2 positive which had a problem really had a MICA related antibody directed towards that donor. We get MICA typing kits and we can set it up, but you know, in today's world where the number of volume is very less, this might be an overkill at this point of time. So presently, I do not keep kits for this. But we can do MICA SAB and we can identify. Now let us switch to AT1 and endothelin receptor antibodies. So elevated level of angiotensin angiotensin 1 receptor antibodies and anti-endothelin 1 type A receptor antibodies were observed and associated with cellular and humoral rejection of early onset. Obviously, because you have endothelial antibodies and allograft is gone, there is a little bit of ischemia reperfusion injury, it will immediately cause a response. AT1 receptor antibodies mediated ABMRs involve complement independent pathways and a stronger effect of acute vascular rejection, malignant hypertension in renal transplant recipients have been described in these type of antibodies. Antibody-mediated non-HLA immunity due to its chronicity can have an important impact on gradual progression of vasculopathy. So chronic ABMRs in lungs, in hearts, in kidneys are seen with these type of antibodies. Patients with both AT1 receptor antibodies and DSAs have a lower graft survival than those with DSAs alone. So this is a very important point to remember over here. Endothelin receptor antibodies is a vasoconstrictor peptide originating from our endothelium. So AECS will lead to AMR. C4D stains are negative because the complement is not activated. So endothelial antibodies enriched for non-complement fixing subclasses IgG, Ig4 are present. So ETAR antibodies are expressed not only in vascular cells but also in cardiomyocytes, fibroblasts and immune cells. So AT1 receptor antibodies and anti-ETAR cause microvasculopathy characterized by proliferation of vascular smooth muscle cells and remodeling of capillaries. So these directly attack the vasculature. So you might find a TMA-like picture when you see these kind of rejections, and they are pretty severe and occur very early during transplant. Now, the available tests cannot identify if these are against the donor because we are detecting the presence of AECS in the circulation. What if these are autoantibodies? But these auto are also causing a damage because they are attacking your own endothelium. There is a test known as X1 cross-match, which can identify if these endothelial antibodies are donor specific. So like you have CDC cross-match, like you have a flow cross-match, which does a lymphocyte cross-match against the donor lymphocytes, you have X1 cross-match, which does a cross-match with endothelial cells to look into non-HLA antibodies if they are donor specific. So this is the mechanism where you have a peripheral blood endothelial cell precursor. You have antigens on it, and if you have a serum which already has an antibody which goes and binds, you can find out from the serum assessment. The test is similar to flow cross-match which we are doing, but the targets are different, the cells are different. So you collect the blood, you centrifuge them, you isolate the endothelial cells, you collect the recipient blood in a serum. Obviously, you need the serum of the recipient. You incubate them with the donor cells which have been isolated, and then you add the FIT-C, and then you analyze in a flow cytometer. In a flow cytometer, you have to gate the endothelial cells and you have to see if there is a positive reaction or a negative reaction. So this is read by a flow cytometer. So this is a very good test which can tell me whether it is a donor-specific anti-endothelial antibody or not. So this was developed to detect antibodies causing hyperacute rejection in patients at Karolinska Institute in Sweden. So this test was initiated over there. It was a multi-center study where they were testing for non-HLA DSAs. And the study sample size was calculated to be 280 patients. Okay. And the recruitment was with a lymphocyte cross-match and an endothelial cross-match to be done pre-transplant. So decisions about transplant and immunosuppressive treatment were based on the routine parameters, and the endothelial cross-match was not revealed to the physicians. If a rejection episode happened, then the responsible staff was informed about the X1 results before making the decisions about the immunosuppressive treatment. And there were equal amount of people who were there. There were more Caucasians, less Afro-Americans, Hispanics were 2% and others were 10%. Now you can see X1 positive 46%, X1 negative 12%, total of 20%, which were showing a positivity. And you can see the distribution of PRA levels. X1 results correlates to rejections, but PRA levels did not. So in this study, they could not correlate the PRA levels with the rejections. So if you see the X1 positive, total 46% at rejection, X1 negative 12%, total 20%. And X1 assesses the risk for acute rejections in kidney transplant recipients. So now if you see this, no rejection in these green bars, but the X1 positive cross-match results correlated very well with the rejection episodes. It very directly said that people who were positive for this test experienced rejections very early during transplantation. If you look at this, X1 negative 0% had rejection. If you are positive, then 6%. C4D negative rejections, 29% as compared to 12%. So creatinine levels were also very significantly higher in X1 positive, X1 cross-match positive recipients. So the study conclusions were that X1 positive patients experienced significantly more rejection than X1 negative patients. X1 cross-match positive patients experienced earlier and more severe rejections than X1 cross-match negative patients. X1 cross-match positive patients had higher creatinine values at 3 to 6 months post-transplant. So we have also noted a similar thing in whatever studies we have done with the samples in our lab. So summarizing the X1 part, acute rejections occur in HLA negative patients. A multi-center study which was published in 2009 showed that the HLA negative patients, 24% are positive to non-HLA antibodies identified by X1. As shown by Brimer, X1 positivity is a risk factor for early rejection. In patients being HLA negative in standard assays, we would like to know more then. So these were the multiple studies. Now we are looking at 81 receptors. So these are multiple studies where we have seen that biopsy samples are showing a C4D negative type of a rejection. 81 receptor antibody is positive. In few, there is a synergy with DSAs. So if you have an HLA DSA, so if you see here, there is a synergy. Here, there is a synergy. Here you have kidney recipients, you have heart recipients. They are studying the post-transplant detection of antibodies and the key findings at the biopsy. Most of them have been C4D negative, like we explained in the pathogenesis. Two studies showed that one study in the kidney and one study in the heart showed that there is a synergy with HLA DSA. So if you have DSAs and you have 81 receptor antibodies, you have a stronger rejection. And the threshold for detection should be lower so that the treatment can be done. Now, this is a study from Frontiers in Immunology. This is a recent study of 2021 where they retrospectively assessed patients with transplant biopsies scored following PAN-15 classification. Pre and post-transplant serum samples were checked for HLA and non-HLA antibodies where MICA was checked, 81 receptor antibodies were checked, endothelin type 1 antibodies were checked, and the cross matches with primary aortic endothelial cells. So they picked up a piece of aorta, teased out the endothelial cells and did cross match with them. So this is a very ideal study. Also analyzed HLA epitope mismatches. So this is a high-end study which could be done in today's settings with all the technology available to try and see their role in ABMR. So 118 patients were studied. Normal histology, so these were only rejection patients. Normal histology was seen in 19 patients, ABMR was seen in 52 patients, and IPTA was seen in 47. ABMR patients which were DSA positive were 73% and DSA negative were 27%. Pre-transplant HLA DSA and 81 receptor antibodies were more frequent in ABMR related rejections histology compared with IFTA and normal histology cases. So if you have a synergy of HLA DSA and 81 receptor antibodies, you had the histology suggestive of ABMR more often, without differences in other non-HLA antibodies. So MICA and AECA did not correlate well with the histological findings of ABMR. Only 3 ABMR related histology DSA negatives showed non-HLA antibodies. Pre-transplant 81 receptor antibodies may synergistically act with preformed de novo HLA DSAs to produce ABMR histology and DSA positive rejection. multivariate analysis also showed that a synergy of these, so the presence of both of these were independent predictors of ABMR, histology and DSA positive. So that study was important. Then there is another study which has studied the endothelin 1 type A receptors on early transplant outcome. And here they have prospectively studied the presence of anti-ETAR antibodies in 116 consecutive renal transplant recipients pre and post-transplant screening. So before and in the first, third, sixth and 12th month post-transplantation. Additionally, the presence of anti-HLA antibodies were assessed by flow PRA using 1 lambda kits. 81 receptor anti-ETAR receptors were assessed by ELISA kits. The concentration of anti-ETAR IgG antibody were measured by ELISA method, and the cutoff was kept as more than or equal to 2.5 units per ml, and it was negative less than that. The diagnosis of acute rejection was made by Manfredi. Now, if you see, the anti-ETAR receptor antibodies were observed in 55, that is 47.4% of the analyzed recipients before transplant. And the patients were divided into two groups, anti-ETAR positive and negative. If you see, the patients who had a positive antibodies to the endothelin type 1 receptors, there you can see a higher creatinine level as you go by. Whereas the people who were negative were showing a lower creatinine level, which we also saw in few of our patients. So cases with mild to severe intimal arthritis were often observed in patients with the presence of endothelin receptor antibodies comparing with the patients who did not have. The incidence of vasculopathy or arthritis was higher in ETAR antibodies. The mean level of ETAR antibodies was around 9. So the cutoff is 2.5, but people who had acute rejection had very high antibodies. Now, what is non-HLA autoantibodies? Till now, we have seen MICA, we have seen AT1 receptor, we have seen endothelin receptor antibodies, which are commonly assessed in our population where we cannot identify what is wrong. What are autoantibodies? In contrast to HLAs, which are constitutively expressed on cell surface of allograft endothelium, autoantigens are usually cryptic and become exposed after tissue damage prompted by the ischemia reperfusion or allograft rejection. The tissue damage seems to play an important role in both fueling and production of these autoantibodies, and if persistent, allowing these autoantibodies to react with the antigenic target, therefore enhances the inflammation at the sites of injury. So you have an allograft. This allograft is the surface is denuded. Antibodies are formed against the allograft. So these are auto, but these are allo. If you go to see it in that manner, because they are against the donor allograft and not against the recipient. So this is a cartoon which shows that you are transplanting a kidney, you have an ischemia reperfusion injury or an alloimmune attack. You have autoantibodies against anti-LG3, anti-AT1 receptors, anti-apoptotic cells. These autoantigen exposure causes autoantibody recruitment, complement activation, increased migration of the inflammatory cells, and there is a severe vascular rejection because they bind to their target and increase the vasoconstriction and the inflammation. This is another cartoon where you have ischemia reperfusion injury, or there is a native or a transplanted kidney. So if you auto-transplant a native kidney also, sometimes you can find this microvascular damage where a pre-existing anti-LG3 autoantibody can be found, and there is a peritubular loss, fibrosis, enhanced damage, and acute kidney injury or delayed graft function. What are the diagnostic options available to us for non-HLA antibodies as of today's date in India or abroad? So in India and abroad, we have ELISA kits for AT1 receptors and anti-endothelin antibodies. Typing and screening kits are available for MICA. So you can do SAB, single antigen bead assay for MICA like you do for HLA antibodies. You can do a screening also like you do a PRA. You have typing of MICA like you have HLA typing. So this is available to us. Cross-match for anti-endothelial cell receptor antibodies is not available in India because the vendors are not providing kits to us. I have inquired in US where there are active centers doing non-HLA antibodies, but they also say that these kits are now not available to use to them. So everyone has an ingeniously made technique where they tease out the endothelial cells of the donor and they do a cross match with these. So that can be done. What are the treatment options once you diagnose? You have to be pretty sure that this is a pathogenesis of a non-HLA antibody, but essentially the interventions remain similar. So antibody depletion in the form of PLEX and IVIG, proteasome inhibitors, we have studied in rodents, so we do not know whether bortezomib is going to work. Complement inhibitors, because the complement cascade is activated. In cases of AT1 receptor antibodies, one can add sartans in the addition to plasma exchange. We actually had a patient which I should have shown here, but this is a case whom I can relate where it is a 55-year-old male who underwent a living donor transplant, I think 2 years ago at our department, donor being his wife. In the first week of transplant, he did not function, and it was a living donor transplant. We did everything possible, but we could not salvage the kidney. The patient listed for a deceased donor transplant because he lost that allograft which was given by his wife. Now, at that point of time, our lab was not doing non-HLA antibodies, and I was at that point of time validating. This was in 2022. I was validating the non-HLA samples to ensure that the testing is correct. And I had taken one of his sample, and his sample had shown a very strong AT1 receptor. But because I was validating, I did not feel it necessary to inform the team because the graft was lost. When the patient presented for deceased donor transplant, I brought up this point with the team that, I had validated our samples or our testing with this patient's sample. I still have the sample saved and it is highly positive. Why don't we test it again? Because by that time, my studies were validated and we could commercially use these assays. Lo and behold, the AT1 receptor at that pre-transplant sample was also strongly positive. So with the get-go, we started losartan for this patient. Post-transplant, the patient did have acute rejection, but we intensified the sartans, we gave plasmapheresis, and the patient is doing well with the surviving allograft today. So this was a very typical case of AT1 receptor antibodies because we had ruled out each and everything. Now, autoantibodies may also be blocked by bortezomib if therapy started pre-transplant. So if you find that people have a lot of antibodies pre-transplant when they have lost one allograft and going for second allograft, you can employ these methods pre-transplant to ensure that the second allograft is not lost. Suppression of early events of endothelial activation is also helpful. Everolimus and sirolimus have been tried, but this is dicey because in the first week of transplant, you and me are not going to try and use everolimus and sirolimus because it will cause a delay in wound healing. Now, I will end up with showing a little bit of our data. Anti-endothelial antibodies, total cases we have tested is 55, out of which 29 are positive. Okay. And the reason for testing these is post-transplant ABMR without the presence of DSAs. And one was positive where a pre-transplant workup was done where the previous allograft was lost and the cause was not known. AT1 receptor, 53 patients have been, samples I should say, have been tested. 15 positive out of these in post-transplant with ABMR without DSAs and 2 positive where pre-transplant workup was positive. So 34% AECA positive and 21.79% AT1 receptor positive amongst the patients whom we have tested for these antibodies in our lab. Non-HLA antibodies and autoantibodies we have seen that lead to inferior allograft outcomes, so should be monitored pre and post transplant if we have had an evidence of non-DSA related rejections. Ischemia reperfusion injury may induce auto non-HLA antibody formation. Association of allo and autoimmunity and tissue injury may cause allograft dysfunction. Many studies have documented the co-presence and synergistic effect of 81 receptor antibodies and DSAs against the donor HLA, causing severe graft injury, which can lead to the allograft loss. Occurrence of ABMR in recipients with HLA identical siblings should raise suspicion of a MICA antibody and other non-HLA antibodies. Accessibility of test kits, reagents for diagnosis still remain a challenge, but if we have centralized availability, then yes, we can provide this. At present, I am providing most of this, but we have to understand that we cannot screen everyone for this. We have to pick and choose. So whatever the data I have shown, these are all done for cause. These are not done routinely. So no one is telling you to monitor these routinely like you monitor for HLA antibodies. These are only done when you have a raised suspicion. And I will end there and take questions.
So thank you, madam, for that extensive coverage. I mean, so to start with, ma'am, like, what is your experience with? I mean, how often do you see DSA negative patients, and like how would you approach that? Would you think that this could be more like a technical thing, and you would want to repeat the single antigen beads, or maybe look at say proson phenomena or something? These are things we have discussed previously. So is that more common, or like what is your algorithm?
So my algorithm is that once if I have done the testing in my lab, I'm pretty sure that it has gone through properly because every sample goes through very stringent analysis. So once the junior technician has analyzed, my senior technician will analyze, then the chief technician will analyze, then it will come to me. When I check it, I look at all the controls, I look at everything, whether the donor is, everything is checked, and then the report is made. Now, in that, if in one of the samples which we have evaluated, if I see that something is not corroborating, I will remove the report again. I will look at the run on the computer again to ensure that everything was all right. And then I will tell the team that, look, something is amiss. Please check for HLA, non-HLA antibodies. And we find it in at least 5 to 6% of the population where we see that DSAs are absent and there's an ABMR and the response to therapy is very poor. That is a very strong indication. So if you give solumetrol, which is a routine practice, you start with plasma exchange when you think that this is an antibody mediated rejection and still the response is poor, then look for these. So my indication to look for non-HLA is when I see that the baseline evaluation has been good. I cannot corroborate the ABMR to the HLA antibodies. The response to the therapy is poor. Then I look for these antibodies. So we do not want to spend money on these tests unless we are very strongly indicated.
And next, ma'am, there is a question from Dr. Praveen Etta. So, like, do these non-HLA antibodies, are they expressed on the lymphocytes, and does CDC identify them? I think you covered a bit of that.
So lymphocytes do not express this. Hence, your CDC and flow cross match will always be negative. Imagine, so you are doing cell-based cross matches. So flow cross match is very sensitive. But when you are doing the cross matches, you are teasing out the lymphocytes. You do not have all the cells. And your flow cross match, if you ever see the run, you will see only lymphocytes which are gated. So you will never pick these up. So these are the caveats in your cross matches. They pick up non-HLA, but they pick up non-relevant non-HLAs which are not relevant to you and give you false positive cross matches. They do not pick up the relevant non-HLAs because they are not expressed on the lymphocytes.
So another thing is, ma'am, like the standardization of these tests. So is how difficult is that? Because I mean, typically it is very difficult to find standardized serum.
So it took me at least it took me 3 to 6 months to standardize because and I'm finding a clinical correlation. So it is very good. We had to do the units. There was a lot of studies which I had to do before I could even think. So I have actual tissues stored, elute of tissues which I have used for the test. Lot of scientific experiments on the baseline level which I have done. So it takes time.
Right.
because not everyone is doing it. Even in US there are only a few things, like in our transplant immunology conference we had invited a few international faculty who were working on non HLA, and they said that it's not easy, and most of the times you have to try and correlate clinically rather than just say that, oh, this is positive, this is the cause. So I would say a robust basic evaluation, like your CDC cross match, your flow cross match, your HLA typing should be complete, because most of the times in our country people don't do complete HLA typing. So I do not have the donor HLA to even confirm that the HLA antibodies against the donor are absent. So we need a complete analysis, thorough analysis of the baseline. Then you can go to the non HLA level of testing.
So another thing is, ma'am, you have explained a little bit about how we can use endothelium based assays. So once you take peripheral blood, so you may get some
But they are
endothelium.
very less. So
Yeah,
lymphocytes are
and then
around 10 to 15%, and endothelial is less than 2%.
okay, so is there some damage that happens to the cell? Can that lead to false positive tests? Like how good are these assays?
But that is why you have to correlate clinically. No? So if you find a non HLA antibody and you do not have anything happening clinically, you cannot corroborate to anything. No?
Yeah, so that has been highlighted as a very important issue with these tests which are using peripheral blood endothelial cells, right, man? Okay, and the thing is, like, suppose you have nicely explained about how we can use these HLAs, the lab screen method, so that we can get the MIC antibodies, so and at least in a qualitative way. So is that what you are like currently doing for
But
most of your
it
patients?
does not have a lot of. Initially, I did not have the Mickey kits for SAB. That time I was using the screen.
Okay.
But I have realized that it does not cover all the HLA antibody, all the Mickey antibodies. So hence, I am now using only Mickey SAB even to screen.
Okay, so what is the usual cost that a patient will have to go through?
So
Way.
I will have to check with the reception desk, but the comprehensive non HLA antibodies, everything together, Mickey 81, ACA, and the list of Vimentin, tubulin, all those cost around 25. Everything together. If you have only 81 and ACA, it is hardly 5,000 to 6,000. If you have only Mickey, it will come to around, I guess, 10 to 11,000.
And suppose like the one of the issues with our presentation was that like somebody wants to start a new lab, or is this
So I have
somebody.
shown what methods are used.
So would you think a stepwise approach of getting a maybe a few the more common kits would be more appropriate and something of that sort? How should one approach that?
No, because this does require. So I had actually gathered all the sera of patients where I couldn't explain. So it was a very huge process. From 2020 to beginning to the end till I could start, I had to do a lot, because see, no one does in our country. So I have to ensure that it is done properly, because my unit does a lot of transplants. I do a lot of intestines, hands, hearts. So I need to see that. And I did not show lung and heart recipients, but we have been able to detect rejections to the T, where lung people have not been able to identify, and based on the antibody non HLA I have given, the patient has recovered. So it's a lot of deep work. If someone has to be trained into looking into it, is what I'm saying. It's not like a machine डाल दिया और डाल दिया. मशीन है, reagents है, उसको कैसे यूज करना है, how do you validate it, all those things do require a lot of training, is what I would think, because it took time to me also, where I was trained abroad and I had to keep doing 2 and 4 with the laboratories abroad, and then standardize it and give it up.
I think since there are no more questions, and we are at the end of it. So I'll thank Shruti ma'am for her time, and she's extremely busy with all the work. And I will be hearing from her in the ISOT workshop also. She's going to talk. She does have a talk, and maybe she'll come up with a lot of details and more. I mean, uh, a little bit of more material for the lecture she has. And I'll also take the opportunity to thank all the participants who have been with us through the entire course, starting from the first lecture and till now. It's been a long journey. It has been very enjoyable for me, and I'm very sure that most of the people have also learned a little. So I welcome you all to the transplant immunology course. I mean, I'm very sorry to say that the course is, I mean, it is already booked to the brim, and we had to actually change the mechanism of how we were going to do it because of the logistic constraints of the lab. So all those coming, we are I mean, warmly welcoming you all, and let us see how we can go ahead and take this to the next session for the lectures and the immunology course. So thank you one and all. Thank you, Shruti ma'am. Have a good night.
My pleasure.